men at 27%. When you break it into urban and rural, then you are able to see that urban, the coverage of the proportion of urban residents who are covered by health insurance is higher than that of rural. And of course, in urban, men tend to be more covered than females. But really, 39 and 41 are not really big differences. Now, you can see it is low. And I think for what I got in the night, that is the reason as to why we do not have the CS Health, PS, the two PSS and the DG Health, because they are discussing this thing, that issue of insurance coverage for the population at a high level, and that's why they are not here, I believe. So with that said, we move to the next one. We made an attempt of having some component on disability. So we had a module for disability in the questionnaire. And so we dealt with the 6 domains of the Washington group of questions that are recommended for such an activity. This one is actually meant for census, but because we are not doing full-fledged disability survey, we confined ourselves to the Washington group of questions that are meant for surveys. And so the coverage is as what you are seeing. The highest cases of disability is on vision, which is seeing. And then the next one is on walking or climbing stairs, that is physical. And then you are able to see that females are more affected at 12% and men at 10%. Now, these figures are slightly different from, they are higher than what we got from the census. These figures are higher, and you know, surveys normally are more precise than censuses, and so we are comfortable with what we have. Now, the next slide is on the education level of survey respondents. This is key. This slide here is very key, because it has given the characteristics of the population that we dealt with to give us these results. So first of all, we confined ourselves to those who are within the age of 15 to 49. And within that, the education levels are and distribution is indicated by the 2 bar graphs that are there. So we have for men, we have for women, and we have for men. Those that did not have education at all, we have women being at 6%, and females being at 3%. In terms of those who had a primary level of education, they were the same at 36. Those who had secondary, not very different, 38 and 40. And so that is basically the distribution of the population that we covered in our sample as at the survey time. So those characteristics will play in a big way in the analysis of the results. Yeah, you might not be able to see all of them here, but when you go to the report itself, you'll be able to see the breakdown of analysis done by indicators and looking at different levels of education. And that's how key that particular slide is. Then the next one is what one would want to pick and run away with, and that is the fertility level that we have received from this survey. We have noted from the results that our total fertility rate is 3.4%. This is down from 3.9% that we had in 2014 DHS. And as you can see from the trend, we have had the fertility levels going down. And this is the joy that we have, we still expect it to go down if our policies and interventions are still pointing in the right direction. But there's a disclaimer to what you are seeing on the screen, that the previous DHS series of 89, 93, and 98, we did not have the northeastern and the northern counties of Kenya considered in those series of the survey. They were not there. The reason being that at that time, or during that period, the Bureau had not developed the master sample frame for those areas. So we would only cover the rest of the country minus the northern part of the country, because they were ASAL. Okay, because I cannot tell, because I was not there then. I cannot tell much about that. But what I know is that the frame was not covering them. But from 2003, we have managed to have frames that are covering all parts of the country, and that's when it is really representative. And you can see that we have some plays around 5.4 and 4.7. Otherwise, I'm sure if they were covered, those figures would have been a little bit up, and you'd be able to see a trend coming downwards, as it is depicted from 2003 onwards. Now, the next one is on the teenage pregnancy by education level, and this is a slide that is not very good, because ordinarily we would not expect to have teenage pregnancies. But as it is from the survey, it stands at 15%, which is not a good thing to see. Now, let's break them down by the levels of education. Remember the slide that I mentioned to you about the characteristics of the population in terms of education levels. For the no education people, 38% of them were pregnant. For those who had primary level of education, 20% of them were pregnant. And the story goes on to those who have higher level of education beyond secondary. 5% of that group were pregnant. Remember, we are restricting ourselves to those who are within the age of 15 to 19. Those are the teenagers that we have considered here. So we can go ahead and unpack it a bit and see what it is at the county level. And this is where we can now see where some of the problems are that we need to tackle. And this is one of the areas where the COG would really need to work hard so that counties can do better. Now, the ones that are indicated red are actually having the highest pregnancy prevalences in those particular counties. So we have Samburu at 50%. You can imagine those fellows of age 15 to 19, half of that group being pregnant in Samburu. Then we have 29 in Marsabit, we have 36 in West Pokot, we had Narok with 28, and we have Meru with 24. I'm not sure why Meru, but the other places you could attribute it easily to early marriages. I'm not very sure of Meru. So those are what we are seeing from at the county level as concerns that particular indicator. Now, fertility preferences, we move to the next. Fertility preferences. This percentage distribution of married women, age 15 to 49, by desire for children. So we are restricting ourselves to the distribution married women of ages 15 to 49, So those who desire to have another child, 30%, another child later, 30%. Those who are willing to have a child soon is 17%. Those who do not, those who want no more, or those who are sterilized at 46%, and those who are declared infecund, that is those who are not able to give birth, are 2%. We move to the next, which is current use of family planning, and we are able to see we have two main ways of family planning methods. We have the modern method, we have the traditional method. So for those who are using the modern method, they are 57%. And those who are using traditional method, they were 6%. But at the national level, when you combine all of them, those who are using any method, they are 63%. Now, you could be troubled with the maths there, but when you look at 57, after 57, it is broken down into the various components that feed into the modern method. That is, we have injectables 20, implants 19, pill 8, IUD 4, and there are others which are not given there, like sterilization, use of male condom, and the like, which all of them account for 6%. So when you add those ones, you'll be able to get the 57. But the 6 that is at the end is actually a different 6 for traditional method. So the current use of family planning stands at 63% at the national level. Next. So that is also broken down by counties, and for counties, for the purposes of this of the presentation today, we decided actually just to use the map to show what they are. So it is a visualization that we have done here, rather than listing all the percentages against each county, which then would be very difficult to compare. And so, sorry, I talked of Kenya is 57%. That is modern. Yeah, so we're dealing with modern. Yeah, so it is 57% is modern, just correctly as I had said. And so we have just broken down the use of modern family planning by counties, and you can see those that are very good. The good ones are the good ones are given in. Do you have them in colors? I can see we have 57 Meru. We have Kiambu at 68, Nyeri at 71, Tharaka-Nithi at 68, Kirinyaga at 71, Embu at 75. So those are the those are the best users of modern family planning method. And of course, we have those that are not doing very well, like Samburu is at 25. We have Garissa at 11. We have low cases also, and you are able to see them from the slide. We go to the next one. This is the total demand for family planning. And here we are talking of percentage of married women aged 15 to 49 years with unmet need, met need, and total demand for family planning. So in situations where there's the current use of any traditional method or any modern method, those are demands that are satisfied, and they are accounting for 57%. And this is the very same one that we had seen earlier. Then we have the unmet need, which is 14%. But if you go to the next slide, it will be able to give you more more insight of what is happening. When we are talking about met needs, then we are able to see that from the previous DHS series, and this one we are starting at 1993 onwards, we can see that for the met needs, it has been rising. In 93, the met need was only 33%, which was very bad. It improved to 39, then was stagnated a bit at 39 again in 2003, then moved to 46, 58, and now we have the met needs at 62%, which is a great improvement. And as we are meeting that demand, then it means that the unmet need is dropping, and dropping tremendously, as you are able to see, from 35 to 28 to 27, 26, 18, sorry, and now we are at 14, which then means that there's good improvement. In terms of demand, we are also able to see that it has improved all the way from 68 in 1993 to 76 in the current situation. So we go to the next one, which is on maternal care. And this one is talking to the case of the last 2 years preceding the survey. Percentage of women aged 15 to 49 who had a live birth and or a stillbirth for most recent birth or stillbirth, we can see that those who received antenatal care from skilled providers was 98%. And skilled providers are, when we talk of skilled providers, we are talking of doctors, clinical officers, nurses, and midwives. Those are the categories that are able to help mothers deliver in a safe way. And so it is good that 98% were able to receive antenatal care from the skilled providers. Then there are those who made 4 or more antenatal care visits. It was standing at 66%. And then we have those who received postnatal check during the first 2 days after birth. There was 72%. And so that is not a bad situation. Percentage of live births or stillbirths delivered by a skilled provider, 89, and then delivered in a health facility at 82. Of course, we desire to have delivery in health facilities being 100%. So we move to the next one, which is now breaking the very same slide that we've just seen into counties. And we are able to see those who got assistance during delivery by county. And we have Elgeyo Marakwet having 98%. It is more than it is higher than the average. The average is 89. And Elgeyo Marakwet at the end, it is not colored, but it is 98%. Then we have Samburu. No, we have. I'm trying to get the highest ones. Samburu, I think that's one of the lowest cases. Not, I think it is true. Then Kisumu at 98. We have Nyandarua 98. We have Nyeri at 99. That should be the highest, together with Nairobi 99. Kiambu 98. Those are the counties that have performed the best. But we also have counties whose cases are much lower than the average. Turkana 53, Samburu 57, Wajir 57, Mandera 55, and Tana River 59. Those are the lower cases that I think the systems will be able to help in getting better. Not sure if it's about lack of skilled healthcare providers or it is for some other reasons. Now, so when we look at the trends in terms of assistance during delivery, which is still the very same topic that we are on, but we are looking at it in terms of the trend all the way from 89 to 2022, and we can see there is quite some progress, but of course we still stand with our caution that 89 to 98, we did not factor in the ASAL cases, but generally there has been improvement over time, because in the 2014 it was only 66, and now it is 89. So that is a great improvement. We go to the next one, which is on vaccinations. A child age 12 to 23 months is considered fully vaccinated, that is having received basic antigens, if the child has received 1 dose of BCG, 3 doses of DPT, 3 doses of oral OPV, and 1 dose of measles rubella. I'm seated next to the health expert here, but I did not ask him why Kenya has its own schedule, which has added a few more vaccinations for, in our case. The Kenyan national schedule is having more. So other than what is on the left, we have the last 3 bullets being added there as 1 dose of IPV, 3 doses of pneumococcal vaccine, and 2 doses of rotavirus. So those ones are added. I believe the health guys, when you'll be speaking, make it very clear, because that one I'm not able to make it clear as to why we have the standard one and then we have the Kenyan case. It will be interesting for the public to get to understand that. Thank you. Now, then we move to the next one, which is on vaccination coverage by residents. We can see that those who are fully vaccinated, in terms of getting the basic antigens, it is standing at 80%. And here, it is regardless of the distribution of the population, whether urban or rural, it is 80%. And so that is where we are. But when you do the strict bit of the vaccination requirement, then we have noted that the cases are falling down to, at the national level, it is coming to be 55% rather than 80%. Then for the urban, it is 56 rather than 80%, and for the rural, it is 55 rather than 80%. But all the same, all of them are actually similar. It doesn't matter where the population is. Seemingly, the uptake is kind of the same, regardless of whether you are in urban or rural. But that is the situation. So the strict sense has a lower coverage, and the loose one has a higher coverage. Now, then, vaccination coverage by counties. Again, we have just broken down what we have seen at the national level to what we have here, and this one, it is giving it at the basic, we are talking of the basic antigens, the relaxed case, which is 80% at the national level, and we are able to see those counties that have done very well, one of them being Vihiga at 96%, and we have Nyandarua at 95%, we have Mombasa 93%, Murang'a at 95%, and we have Tharaka-Nithi also at 95%. However, there are also those counties that have not done well, and they have given in red, where we have Samburu 60, Turkana 60, we have West Pokot 49, we have Wajir 49, Mandera 29, and Garissa 23. Those coverages are very low in those counties. And so something has to be done very quickly. Now, symptoms of childhood illness and care seeking. Of course, children are normally very, very fragile at that lower age, and there is a need to check on some key symptoms that would make them uncomfortable. And we have the acute respiratory infection, ARI, and we have fever and we have diarrhea. Those are the main ones that are very common with children. So it was noted that for children, it was 2% ARI, and fever was at 17. Then we have diarrhea for children. It was at fever 17 and diarrhea at 14. Now, these cases, the question went ahead to ask if one sought for treatment, and for the few cases that were noted for the acute respiratory infections, 82% of the cases actually sought for treatment. 70% of those who had fever sought for treatment, and 57% of those who had diarrhea also sought treatment. The next one is on the trends in nutritional status of children. And here we are talking about percentage of children under 5 based on 2006 World Health Organization Child Growth Standards. And we can see it is measured by the element of stunting, wasting, and overweight. And we can see that for stunting, our situation at the national level stands at 18%. Wasted, it stands at 5%, and overweight stands at 3%. And we are also able to see the trend that we have had from as early as 1993, where the stunting cases have been high, but thank God it has reduced over a period of time to the current 18%, and the same applies to overweight. Wasting seems to be increasing just a bit. It is increasing by just a bit, but it is standing at 5%. We move to the next one, which then is also breaking down one of those indicators, and that is on stunting. Stunting by county, we have, of course, we have noted that at the national level it is 18%, and then deeper into the counties, we can see that the counties that are having high prevalence, like Kilifi has 37%, Kitui 25%, Meru 25%, Samburu 31%, West Pokot 34%. But there are counties that have equally done relatively better. In Kirinyaga, it is only 11%, Murang'a 10%, Nairobi 11%. I think those are the lower cases. Then we can move to the next one. Sorry. The next one is on the trends in exclusive breastfeeding. We are guided that proper breastfeeding is meant to be exclusive for 6 months. That is, the child is just meant to get fed from the mother's milk. Now here we are talking of age 0 to 5. The sixth month, made to understand, is meant for weaning, and so it is not fully exclusive. And so when it comes to that, the trend has been given, ranging all the way from 89 to 2022, and it is a graph that seems to be a bit funny, because it has been going down from 89 to 2003, and then from there it has now been rising. But in the current situation, compared to 2014, it is somehow stagnant. I won't say that it's really gone down, because 61 and 60, if you apply the standard deviation, it will really bring you to the same thing. It will not really be any much different. And so our situation currently in terms of exclusive breastfeeding, for those mothers who are lactating, it is at 60%, which has really not changed from what it was in 2014. Then the next one is the childhood mortality rate. Here we are dealing with the situation, with the element of mortality rates for children, and we are talking of neonatal mortality. This is a death of live birth. This is a live birth first. So we are talking first of all live births. For mortality, we are talking live births first. You are born alive, but this child has died within 28 days or the first month of birth. So that is the neonatal mortality. It is at 21. It is at 21 deaths per 1,000 live births. Then for the post-neonatal mortality, those who are dying between 1 month and less than 1 year is 11 deaths per 1,000 live births. And so if you look at the infant mortality, which is putting the neonatal and the postnatal mortality together, we are talking of those who are, the children who are dying before they celebrate their first birthday. They were a total of 32 in 1,000 cases. The next one is the child mortality, which is from 1 year to under 5. There were nine cases in 1,000 live births. And when we talk of now under 5 mortality, then we are adding the infant mortality and child mortality, which then gives us 41 cases per 1,000 live births. We then move to trends in childhood mortality, that is death per 1,000 live births for the 5-year period before the survey. 5-year period before the survey takes us back to 2017. Yeah, 2017. So under 5 mortality, we can see the trend from 89 coming all the way to 2022. It was rising from 89 up to 2003, and then started slowing down. So our situation got better, and currently we are at 41 per 1,000 live births. And for the infant mortality, we are at 32 deaths per 1,000 live births. And of course, for the neonatal mortality, it is 21 per 1,000 live births. So at least for these indicators, in terms of child mortality, there has been quite some improvement as compared to the past. So the next one is on the trends. I hope you'll bear with me. I'm not far from finishing. But remember, we are still just dealing with the key indicator report. You know, the main one is massive. So Kenyans will be bombarded with a lot of statistics to get the indicators to help them. So then trends in this is the insecticide-treated nets, and we're talking of the ownership. And when we talk of ITN, the insecticide-treated nets, we are talking of the nets that have been treated at the factory, not the ones that are socked. You know, we get those whatever and sock them. No, we are not talking of that. I think that was applicable in the previous years, but I think in the last series of DHS, we are restricting ourselves to those cases that for the nets that are treated at the factory level. And why are we talking of the nets? It is because of the high prevalence of malaria-related deaths in the country, and so it is an area of concern. I know we normally undertake malaria indicator survey very regularly, but when we have a chance of this nature, we decided to take advantage of that and also see what is happening at the national level. And so we have these results that the households that had one or more nets, ITN nets, is 54%, and those who had one ITN net for 2 people, for every 2 people in a household, they were 37%. And our situation seemed not to be doing very well for the first case, because we have moved from 59, ownership from 59 to 54. We need to really understand what is causing that. Then use of the ITNs, that is the next slide. Percent of people who slept under an ITN the night before the survey among all households. We are noting that for the under 5, they were 75 in the lake endemic counties. That is, those counties that are commonly experiencing the incidence of malaria. And then at the national level, it was 51%. Now, for the pregnant mothers, because these are very vulnerable group of people, if they are attacked by malaria, we are noting that at the national level it was 45%, and at the lake endemic counties, the cases were 75%, those who slept under net. So they are aware of this, and it is higher than the national one. Then percentage of people who slept under an ITN net the night before the survey among households with at least one ITN net is, we have 77 for children at the national level, and in the lake endemic counties, we have 80%. For the pregnant mothers, we had 75 at the national level and 82 at the lake endemic counties. So that is now broken down. So what is it that we are breaking down? We are breaking down the cases of those who slept under net the night before the survey among all households. And that is what is broken down now into counties. And we can see that the cases that had fewer, the counties that had fewer people sleeping under net, we have Nyandarua at 9%. We have Garissa at 13%, Samburu 10%, Marsabit 9%, Mandera 9%. But then there are those counties that had higher, that did better by sleeping under net, and these ones are basically those that are to the west. I can see there is Bomet at 76, Nyamira 81, Migori 76, Siaya 77, Vihiga 79, and so that is the distribution. We move to the next one. We are not far from finishing. Fever in children. This is percent of children under 5. Then for the children under 5, those who had fever in 2 weeks before the survey, there were 17 of them. This slide, I don't know why it is here, it should have been connected to the earlier one. Then they have the percentage of children under 5 with fever in the 2 weeks before the survey. So we had those who actually sought for treatment were 70%, and those who had their blood taken from a finger or heel for testing were 33%. At least a good percentage of those who had fever 2 weeks before the survey were reported to have sought for medical attention in terms of treatment and also testing. The next one is on knowledge of HIV prevention methods among young people. Here, we have moved away from the perception that we had earlier on the HIV prevention methods in terms of perception. but we are focusing on the youth who are between 15 to 24. This question was applicable to those who are within the range of 15 to 24 years, and the remark is made there that knowledge about HIV prevention means knowing that consistent use of condoms during sexual intercourse and having just one uninfected faithful partner can reduce the chance of getting HIV. That is one of the knowledge that was being tested. Then knowing that a healthy-looking person can have HIV, and that rejecting also rejecting the two common misconceptions about transmission of or prevention of HIV, that is, HIV can be transmitted by mosquito bites, and a person can become infected by sharing food with a person who has HIV. So those, we are testing the knowledge of those misconceptions also, and we take note that at the national level, those who are within that age, those who have the correct knowledge on this, at the national level, it was 54 for women and 55 for female, which is basically the same. Broken down into urban and rural, higher knowledge was in the urban at 57 and 63, and like rural at 52 and 51. So HIV testing here, we normally undertake the Kenya AIDS Indicator Survey, which the last series in 2018 was KNBS, a modified version of the AIDS survey, and we had good results from that. But here we are not testing; we are just getting to find out from the respondents if they ever got tested and received results, and those who were tested in the last 12 months and received results. So those who were ever tested and received results, for women, they were 85%, and for males, it was 72%. Those who were tested in the last 12 months and received the results, for women, they were 47, and for males, it was 39. So we also, again, just took advantage of this survey to see the situation, to get to understand the situation in terms of HIV testing in the country. But there are more details that will be coming from the main, when we have the main report done. Now, the next one is on the experience of physical violence. So we are on the violence one. And here we are talking of a case where we are talking of percentage of who experienced physical violence since age 15. So this question was trying to get any cases of physical violence on the respondents since age 15. And we can see that at the national level, for the specific group that we are targeting, we had 34% being women and 27% being men. So that means female really get more physical violence meted on them than their male counterparts. And of course, the distribution by ages is given in the graph. You can see it is rising, like for women, it is rising, but you see it is actually a cumulative figure. So you would expect that those who have lived longer have seen more than the younger one. That is depicted in the results. Now, women's experiences of physical violence by county, and we can see that when we break it down, we are able to see that there are cases that look serious, while the national prevalence is at 34%, Bungoma is at 62%, and Homa Bay 54%. Migori, 51%. Muranga, 54%. Those are the higher cases of where physical violence have been experienced by the respondents as captured from the survey. And of course, those are cases where attention would be required. And I think, and this for females. So females, you know, there are safer areas to be in. There are safer areas to be in. I can see here. Mandera is only 9%. Okay, I'm talking of only as compared to 34, but it should be 0. Yeah. My only should not be misconstrued to mean something else. So the Mandera is a bit mild on that. Wajir 13%, Marsabit 16%, and Kericho 16%. Oh, of course, Kitui has 12. Oh, I thought in the Nyanza region, these are the guys who knew how to take care of ladies, but I'm seeing something different. Well, all the same, that is life. There's room for improvement. Now, the next one is on the experience of sexual violence. And here we are talking of percentage of those who have ever experienced sexual violence. Ever. So that means it is also cumulative. So apart from the first part of the graph, which is giving us the total cases at the national level, which stand at 13% and 7% for women and men respectively, the others are just broken down by age groups of 15 to 19, and that goes all the way from up to 40 to 49. And so you can see that the percentages are rising as you get to those older ages, because we are talking of ever experienced. So we take it from this slide that total cases of sexual violence is at 13% for females and 7% for males. Now, women's experiences of sexual violence broken down by county. Again, we can see that while it is at 13%, there are counties that are high, and Bungoma is still there with 30%, Homa Bay 23%, Nyandarua 18%, Muranga 24%, Embu 22%, but the counties that really don't have so much of that problem are Marsabit 1%, Mandera 1%, Wajir 1%, 2%, and so you are able to see the rest by yourself. Now, trends in female genital mutilation. We had the questions that were speaking to this. And here, we have noted that in 2022, the cases have gone down from 21% to 15% in 2014 as compared to 2022. And when you see the trend, in 98, it was much higher, 38%. It has been reducing. It has reduced up to now 15. But the interesting one is to see where we are. Yes, the lower cases of this nature is very important. But let's see the next slide. The next slide is now breaking it down by ages. So we have 15 to 19, all the way to 45 to 49. And you can see that for the older cases, the prevalence is higher. For the new cases, it is much lower. It is 9, which is lower than the average. So it means we are making good improvement on this. That those who are currently 15 to 19, we have lower prevalence as compared to the older folks, as you can see here. And so that is a sign of very good improvement. But I'm sure Bernadette would want to have it as at 0. Yeah. So that is basically the end. The last slide is just giving the key highlights of what I've presented here, which I might not need to really repeat, but it is the way it is on the screen, where we have the key findings, TFR 34, married women age of that using modern method 57. So if you followed the presentation, then this is just a summary of what has happened. So I would want to stop here, and I promise that, as had been said by my chairman of the board, we are working hard to have the full report being available in the next 3 months. But this work does not end there. We now need to ensure that the findings are well disseminated, and beyond dissemination is putting into good use what we are seeing. Where policies are required, we come up with policies. Where interventions are required, we come up with the right interventions. And so this is the work that we are now handing over to the Ministry of Health that will be dealing with it. We are handing over to Anti-FGM Board. We are handing over to National Council for Population and Development, NCPD. We are handing over to State Department for Gender. We are handing over to National Gender and Equity Commission. And we are handing over to all the players who are relevant in this. But of course, we are open to offer support where it's required. Let me not stop before mentioning the fact that we'll be finalizing on the main report, but our sister organization, NCPD, is now taking over the element of in-depth analysis of the results that we are seeing from this report, so that they can now dig deep into what is happening. They'll be able now to coordinate that bit. And so the Bureau will now step aside and NCPD come in front to deal with the harder part of it. We have given the easier one of the statistics. And of course, all the players will now come on board to support this process. That marks the end of my presentation, our chief guest. I would stop it at that. I think there would be a few interactions, maybe not here, but I think there have been some TV engagements that have been lined up where there would be questions and answers and looking deeply into what is happening by a number of players in this sector. So thank you for listening. Thank you for being very attentive. And let me hope that what is going to be launched here will be of benefit to the people of this country and beyond. Thank you. Good. So that marks the end of Obudo, the presenter. So let me now take over another role to be the MC for a moment. And at this point, colleagues, ladies and gentlemen, I would want to get to the next part of the program, which details more speakers. And the speakers, we were meant to have the Director General for Health, whom I explained the circumstances of as to why he is not here. And the Director is represented by none other than Dr. Helen Kiarie. Dr. Kiarie has been part of this process and very, very knowledgeable of what is happening and has really supported the process. So welcome, Daktari, to make remarks. Good.
Good morning. Asante, Bwana Director. Our guest of honor, Principal Secretary, State Department of Economic Planning, U.S. Ambassador to Kenya, UN Resident Coordinator, Dr. Stephen Jackson, the Chairman of the KNBS Board of Directors, KNBS board members, Dr. CTNA, who is my boss, studying in for the CS, Minister of Health, Dr. Lenai, who is also my boss, studying in for our PSS, Director General, NCPD, Director General, KNBS, CEO, CEO Council of Governors, representative, our development partners, government officials, distinguished guests, ladies and gentlemen, good morning, almost noon. Good morning. Yeah, so as the director mentioned, I work for Ministry of Health in the M&E division, and we are happy to really launch this report. So I'll give these remarks on behalf of the Director General. So the Kenya Demographic Health Survey informs the Ministry of Health on progress made in health indicators and informs the impact of investments made. And this survey gives us the progress we have made over the last 8 years. And this actually coincides with the year since devolution of health services. As you are aware, most of service delivery in terms of health is provided at the county level. So this gives us, as the new government comes into place, a good baseline in terms of what we have gained from our investments in the last 8 years since devolution. And this helps us to get a policy direction that the Ministry of Health take in advancing achievements of key objectives as outlined in our health policy and also in the social pillar of the Vision 2030. So as Director KNBS has shared in detail, we do celebrate good progress made in health in Kenya. We know that the percentage of Kenyans that have insurance has increased from 19% in 2018, according to the household survey that we did on health utilization, to 25%. And we can attribute this improvement to the efforts made in achieving universal health coverage that the health sector, the NHIF, and other stakeholders have really been working on since the focus, we trained our eyes on universal health coverage. However, more remains to be done, as this is way below our target of 85% coverage by insurance for all Kenyans, for 85% of Kenyans by 2030, as outlined in our Kenya Health Financing Strategy. The Ministry of Health is working studiously to reform NHIF, encouraging all Kenyans to take up insurance to minimize the risk of becoming impoverished as a result of illness. Another area that we know tremendous progress is in women's health. I think we can see in the results just shared that Kenya has maintained a steady increase in meeting the need for contraceptives. And we can already see we have the unmet needs for contraceptives reducing to 14% from 2018 in the last survey. And this, as you can see, has actually led to a reduction of about 50% in fertility levels. However, we do note a major issue in terms of teenage pregnancies, which remain stubbornly high, with a marginal decrease to 15%, and this is dropping from 18% in 2014 when the last demographic health survey was done. Counties, of course, with the highest prevalence of teenage pregnancy, as we have seen, Samburu, West Pokot, Marsabit, and Narok, need high-level multisectoral interventions or collaborations to be implemented with urgency to address this issue in order for the country to reap economic development and growth. More success has been noted for women, as seen in maternal health, with sustained universal attainment of antenatal coverage. We are seeing 98% of women attending antenatal care, the first visit, and a marked improvement of the fourth ANC, antenatal attendance at 44% in this survey, and this is compared to 58% in 2014. So following the removal of user fees for maternal health services in June 2013, Leader Mama initiative is what we call this, free maternity services, and Kenya has witnessed, due to these particular investments, we are witnessing a very sustained progress in skilled birth attendance, and this is deliveries in health institutions, rising from 41% in 2003 to 62% in 2014, and to the current 89% in 2022. This has surpassed our health policy target, which was initially 80% by 2030. So we are actually celebrating this as a really good achievement. However, we must now turn our efforts to the quality of services provided in our health facilities to ensure that no woman or child dies due to preventable or treatable causes. We also celebrate the success of child survival and child health as demonstrated in this survey. Kenya has maintained high performance of childhood vaccinations, with 8 out of every 10 children at the age of 24 months or 2 years being fully vaccinated in 2022. Despite and this is despite the disruptions that happened due to the COVID-19 pandemic, where we know we actually witnessed a lot of disruptions in terms of attendance to health facilities. For the first time, the Demographic Health Survey collected information on early childhood development, which revealed that 83% of children between 24 and 35 months were developmentally on track. We celebrate the sustained reduction in stunting of children, which, as you have seen, has dropped from 26% to 18% in the last 8 years. However, even as we celebrate remarkable progress in child health, regional inequality still remains significantly varied. And further, the quality of care has come out as a challenge, as reported in the management of childhood illnesses. We have seen that only 32% of children with diarrhea receive the right treatment, and that is oral rehydration and zinc supplementation together. Moreover, even with significant coverage of maternal and child interventions, we still see an insignificant decline in child mortality, and especially neonatal mortality, as you can see, has remained stubbornly high at the current 21 of every 1,000 live births dying before the age of 28 days. This is a worrying statistic, and we require concerted multi-sectoral efforts to accelerate achievements of the SDG and the Kenya Health Policy goals. This Kenya Demographic Health Survey Key Indicators report has brought to the light the importance of health promotion. We observe that while 97% of Kenyans have heard about TB, tuberculosis, only 54% of young people in Kenya know about HIV prevention, with the lowest awareness among 15 to 17-year-olds, where only 44% of them are actually aware of HIV prevention mechanisms and how they work. And this is, again, worrisome, as this also is a population that bears the highest incidence or new cases of HIV. So, and this is reported in the past HIV survey that we did, known as KNBS in 2018. We find that a greater percent of women, 85%, than men, 73%, have ever been tested for HIV. And we know that knowledge of one's status is the entry point to care and treatment in prevention of HIV. Overall, there has been formidable improvement in health indicators as for Kenyans, as demonstrated in this survey. However, we must work hard to address persistent regional inequalities through localized, county-led programming of health. Primary health care is the vehicle in which the health system can respond to the unique health needs of a household and community in a comprehensive and integrated manner. It is through heightened awareness of health and health promotions that Kenyans can prevent disease, screen early, and provide effective and timely treatment if we are to achieve our UHC goals in a cost-efficient manner. Moreover, it is clear that while barriers to access to care are actively being addressed, the quality of care that Kenyans are receiving is lagging behind, and we would want to train our health systems and health workers on improving the standards of care. In this way, we hope to celebrate a healthier, more equal population in Kenya. Thank you. Those are the remarks by the Director of Health.
Thank you so much, Dr. Helen, for the remarks given on behalf of the DG Health. And as I told you, as we are now handing over to the different government agencies to deal with various components, and from the speech, you've had the intention to tackle a number of issues that we have seen here, those that are actually negative. And so, thank you for that. Ladies and gentlemen, I would now wish to welcome the representation from USAID Kenya, and this will be done by none other than David Gosney. David Gosney is the director, the mission director, USAID Kenya and East Africa. And so, boss, you are welcome to the stage. You know, this is, as I mentioned earlier, I'll remember USAID beyond being in the bureau for this big support to make this a reality. Anytime I was working, people were asking me about DHS. I didn't have a solution. But today, I'll walk very freely anywhere. Welcome, boss. Good, good.
Thank you so much, and good morning, everybody. Mr. James Muhati, Principal Secretary of Economic Planning, and all the other representatives from the Ministry of Treasury, Ministry of Health, government offices, departments, and boards. Also, Ms. Mary Moiti from the Council of Governors, in recognition of all the tremendous work that the counties do in carrying out both provision of healthcare services and also the survey here. Also, Dr. Stephen Jackson, my colleague from the UN, in recognition of all the important role that the UN agencies have played, and also all the other donors that are here and donors that have played in getting us to where we are today, and everybody else here today. Hamjambo. You know, we're all here because I think we share something very, very important in common, and that's a commitment to improving the lives and health outcomes of the Kenyan people. So thank you for being here today, but really even more importantly, thank you for the dedication to that unifying principle that we all have, because it remains a critical part of the future, not just of Kenya, but the world that we see around us today. And that's why I'm really happy to be here today, and not just happy, but truly honored to share a room with you all. and to be able to celebrate the great accomplishments, but also chart a way forward in this really important area. And I'm also happy here because this is the latest great example of the deep partnership between the American people and the Kenyan people as well, a partnership that covers a lot of areas that have been touched on here today that are also very important for improving health outcomes. We've talked about the impact that the drought has had on the health of many people around the world, and that's why the U.S. government and the American people have been proud to provide over 80% of all international funding coming into Kenya to date to support the Kenyan people in this time of need. I know Ambassador Whitman is working very closely with President Ruto to create jobs and economic opportunity for everybody around Kenya because we know that people need the economic resources in order to improve their household incomes and their health outcomes. And today we're here to celebrate the latest example of the partnership between all the donors, including the American people and the Kenyan government, which has taken this really important step in order to chart the way forward. And in highlighting that, there's just 4 quick things I wanted to really highlight. And the first is the tremendous progress that has been made here that I think was showcased in part to us today. As Stephen mentioned earlier, you can't get where you'd like to go, where you're planning to go, if you're already lost or you don't know where you're at. And I think today we've shown that we've taken a huge step not only to knowing where we're at, but deepening that understanding. And we've highlighted some incredible progress that has been made. Almost a two-thirds reduction in child mortality over the last 20 years. I mean, just think about that. People who say that the world is not moving forward don't know these statistics. That's an incredible achievement that the Kenyan people have made. In this survey, again today, I want to highlight that this is the most valid, the deepest, the broadest, the most disaggregated health survey that has ever occurred here in Kenya. And the impacts from this are profound. I know sometimes data and statisticians, they don't get the attention they deserve, but it is the fundamental basis that allows us to be able to move forward, to chart not only where we've been, but to set goals and impacts and targets to enable us to determine where we want to go as we move forward. And that's why, as Mr. McDonald Obudo mentioned, the U.S. government was proud to be able to provide nearly 1 billion Kenyan shillings to support this effort, about 2/3 of the total cost of this survey, because it's a fundamental piece for everybody, the Kenyan government, donors, ourselves, everybody who's trying to figure out how best to chart a way forward and support the Kenyan people. Because there's another thing we share in common, both the government, the U.S. government, the Kenyan government, donor organizations, you all, is that resources are never enough to do everything we need. And that just underscores how important it is that we are very thoughtful and target about how we use those resources. And data in this type of survey enables us to do that. It points us in the directions of need, it points us where progresses have been made, and it points us where we need to focus. And as we see, each county is different. Some areas have different challenges as we move forward. But we know that we have people here dedicated in order to figure out how to do that. I was very privileged just before this meeting to be able to talk to Bernadette from the board working to address female genital mutilization. And we're talking about the tremendous progress that has been made, but we're also talking about how can we get that to 0? What does it take in order to get that number to 0? And just as we set new charts and new goals as we move forward for all the different health sectors, very much looking forward and proud to be able to work with you and use this data to move forward. And that's the last thing I'd just like to highlight is that, if anything else I take away from today is highlighting that we're on the right path together. We're here with a dedicated team of individuals who's dedicated to using this data. I'm just really amazed to see such a large group of individuals here today who are dedicated to using this, again, to improve the lives and outcomes and health outcomes of Kenyan people. And I'm also proud of our health team. I'm here today with John Keenley, who leads up our health team, who works, I know, with so many of you. And on behalf of John, all of USAID, the U.S. government, and the American people, very much looking forward to continuing this journey with you all. Thank you very much. Asante-san.
Thank you so much, Bwana David, for the good and kind words to us and appreciating what has gone on and assurance of working together beyond this. And I'm now getting to a point where when I invite the next speaker, I think I'll not stand again to speak here, but I would just like to recognize the many civil society organizations that are here. They have been supporting the Bureau in a number of ways. GPSGD, the Global Partnership for Sustainable Development Data. We have Development Initiative, we have ICRH, represented by Dr. Professor Gishangi, and a host of development friends. And so you feel comfortable. You have supported us for us to get to this stage, and we value the partnership. So at this point, our chief guest, I would like to invite Dr. Joseph Lenai. Lenai is the director in charge of intergovernmental relations at Ministry of Health. He'll be representing the two PSS who are meant to be here, but because of one reason or another, they had to be away. They could not make it. And so once he comes, he'll do the remarks and then invite the next boss and the next boss until we get to the end. Thank you so much, and feel welcome, Daktari, and share with us.
Thank you. Thank you, DG. As introduced by the DG, my name is Dr. Joseph Lenai. This is the Director for Health Sector Coordination, Partnerships, and Intergovernmental Relations. And at this juncture, I would like to say that moving forward, I think our work is clearly cut with NCPD, MOH, COG. We shall be able to take it to the next level. And in addition, I want just to allude that soon, in the next 2 weeks, we are going to have the health sector intergovernmental consultative forum. And I've just discussed with the representative of the CES, who is in charge of HMIS, policy, and also monitoring and evaluation. This will be one of the key agenda that we shall articulate in that intergovernmental consultative forum. So, as alluded by the DG, I'm here representing the two principal secretaries for health, Dr. Josephine Wahogo-Mboro, who is the principal secretary for the State Department of Public Health and Professional Standards, also representing Engineer Peter Toom, who is our principal secretary for medical services. Apologies from them, our chief guest. I have the harmonized, amalgamated remarks from the two PSs, and allow me, chief guest, to deliver the remarks from the principal secretaries. The representative of the Cabinet Secretary for the National Treasury and Economic Planning, our PS for State Department of Economic Planning, the representative of the Cabinet Secretary, Ministry of Health, the representative of the U.S. government and USAID, the chair, Kenya National Bureau of Statistics Board of Directors, the Kenya National Bureau of Statistics Board members, the Director General, National Bureau of Statistics, the Director General, National Council of Population Development, representative of our Director General for Health, representative of the CEO, Council of Governors, development partners in a special way, USAID, and implementing partners, UN resident coordinator, all government officers present, distinguished guests, ladies and gentlemen, good morning. Happy New Year. It is indeed an honor to have the health sector converge at this landmark launch. The Kenya Demographic Health Survey is a key reference point at the Ministry of Health as it provides invaluable information necessary to guide programming at various levels within the health sector. It is worth noting from the key indicators shared today, there is demonstrable gains within the health sector. We have more mothers delivering in health facilities, which can attribute to the Linda Mama program, and health insurance coverage has increased slightly as a result of dedicated efforts to increase NHIF coverage. Financial protection is key for universal health coverage achievement. The release of this report has indeed come at an opportune time when we are realigning Ministry of Health with sole intention of ensuring that commitments, as stated in the Kenya Kwanza Manifesto, are achieved. Specifically, one of the key commitments is to increase health insurance coverage to 85% by the year 2030. The Kenya Demographic Health Survey 2022 results have demonstrated that 1 in 4 Kenyans have some form of health insurance. Therefore, Ministry of Health is working to reform NHIF to ensure that Kenyans take up insurance to minimize risk of impoverishment due to illness. Ladies and gentlemen, in terms of communicable diseases, we have seen significant gains in the investments made toward reducing the burden of HIV, TB, and malaria, with deaths from these diseases declining over the last decades. We, however, still need to build on these gains. This survey particularly highlights a low level of knowledge on HIV/AIDS among the adolescents who also bear the highest burden of new HIV infections. This could additionally be related with the high rate of teenage pregnancies we have seen, especially among the uneducated adolescents. These are concerns that have arisen over the last couple of years that, as a ministry, together with the counties and our stakeholders, we are continually putting concerted efforts to arrest. Ladies and gentlemen, gender-based violence has been acknowledged globally as a violation of basic human rights, and as we know, this implicates on the health and well-being of any human being. Women, and more often, bear the brunt of gender-based violence. This survey demonstrates that this is still a challenge, with only a marginal decline over the last 8 years among both women and men. We observed a spike in sexual and gender-based violence at the height of COVID-19 pandemic, and although this has declined, we note that on average 1 in every 3 women have ever experienced sexual violence. These are serious issues that, as a society, we need to arrest if we are to secure the well-being of each one of us. At the Ministry of Health, we have strengthened mechanisms to prevent these vices, but we must work as one if we are to succeed. Ladies and gentlemen, following the devolution of health services in Kenya, county governments have made huge investments that have seen an increased number of health facilities, improved equipment, and other infrastructure. We appreciate that the KDHS 2022 has data on key indicators at the county level, and therefore this will form a baseline for conversation with the county governments in reviewing where gains have been made and where more effort or rethinking is needed. This is to ensure that we are investing in areas of greatest need, as it will help us meet our government's manifesto of Afya Bora Mashinani from the perspective of common mwananchi. Ladies and gentlemen, it is now my singular and humble duty to welcome the representative of Cabinet Secretary, Ministry of Health, to give us his remarks, and also welcome our chief guest. Karibu mwakilishi wa waziri.
So I stand here to represent the Cabinet Secretary, Ministry of Health, Honorable Nakumicha Susan Wafula, who got some urgent engagement this morning and she was not able to be with us. So I read her speech. The Principal Secretary, representing the Cabinet Secretary, the National Treasury and Economic Planning, the Director General, Kenya National Bureau of Statistics, the Board Chairman, Mr. Stephen Wainaina for KNBS, the Director General for National Council for Population Development, representative of the Director General for Health, USAID Mission Director, Mr. David Gosney, the COG representative, the Kenya Demographic Health Survey Steering and Technical Teams, KDHS Technical Partners, ICF International Team, Development and Implementing Partners, distinguished guests, ladies and gentlemen, good morning. Good morning. Good morning. Happy New Year. I hope it is not too late for this. By the way, I'm quoting verbatim. I'm pleased to join you as we celebrate this key event of launching the Kenya Indicator Report of the Kenya Demographic Health Survey 2022. My sincere appreciation to the Kenya National Bureau of Statistics for extending this invitation to the Ministry of Health, who is the biggest consumer of the DHS results. Our Constitution ascribes the right to the highest attainable standard of health for every Kenyan. To optimally steer this, the Ministry of Health relies on availability of timely health data that is used for decision-making at various levels within the health system. Invited guests, the Kenya Demographic Health Survey is one very important source of health data that we use to complement routine health data. The last KDHS was in 2014, and it is exciting that we will now have a new reference point based on these survey results. And this is at both national and county levels for key estimates. It is worth noting that among the key areas assessed that are of interest to the Ministry of Health were reproductive health, child health and immunization, nutrition, HIV/AIDS and TB, non-communicable diseases, and gender-based violence, amongst others. As the two directors have indicated, we have made significant progress in most of these areas. Child health has improved, mothers are now accessing professional care in our health facilities, and we are making inroads in controlling HIV, malaria, and tuberculosis. We note that our task is now shifting towards improving the quality of care we provide to our clients to ensure that Kenyans are healthy and optimized to build our economy. It is in this DHS that we have, for the first time, collected data on mental health. As we know, a healthy status of the mental health is key to people running their lives efficiently. With the results available from this survey, we will be better positioned to sustain and restore healthy mental status within our population. Additionally, we took the opportunity to obtain information on indicators of interest as related to universal health coverage and COVID-19. These included utilization of health services at out and inpatient, healthcare financing, and COVID-19 related information, including mortality and vaccination, of all which are important in showing us where we need to invest our efforts. Ladies and gentlemen, the KDHS 2022 designation of results come at an opportune time when we have a new administration of government that has recently begun its tenure. These results are key in evaluating not just the impact of key projects that have been implemented in the recent years, such as Linda Mama program, scale-up of NHIF coverage, and focus universal coverage, but we will also be able to take stock of the gains of devolution of health at the county level. We have just heard that only 1 in 4 Kenyans have an insurance cover. As the Kenya Kwanza government, we are putting in place concerted efforts to strengthen the achievement of universal health coverage, whose key success lie in having access to social health insurance. As such, we call upon Kenyans to take up social health insurance to improve insurance coverage. Other efforts in UHC coverage include strengthening primary health care to ensure that Kenyans can access quality care at the lowest level and that our services are sustainable in the long run. The government has given the highest level of political leadership for UHC, whose achievement cannot be by accident, but rather by design. And we have every intention to make deliberate, well-intentioned, and executed investments in governance, quality health systems, and accountability towards this end. Further, the KDHS 2022 results will serve as a baseline for future investments. Going forward, the Ministry of Health and county departments of health will utilize these results to make decisions on how to better to implement interventions with the objective of achieving optimal universal coverage for all Kenyans. Invited guests, as you are aware, implementation of a survey of this magnitude of KDHS is multisectorial and requires meticulous planning and resourcing. It is worth noting that KDHS 2022 was implemented within the COVID-19 pandemic, was still at its peak. At this juncture, allow me to applaud the Acting Director General, Kenya Bureau of Statistics, for ably steering and promoting innovation and use of technology in the implementation of KDHS 2022. The Acting DG and his team have strived to have the results released in the shortest time possible for use in planning, programming, and decision-making. Additionally, it is worth noting that other countries in Africa are using Kenya to benchmark as they plan their own DHS. This is a win for our country and is something we must be proud of. I also want to appreciate my team at the Ministry of Health, the technical lead team led by the DG Health that dedicatedly worked through the entire process and was involved at all survey stages, ensuring that collected data is relevant to inform policy in the health sector, as well as designing a functional COVID-19 mitigation plan for use throughout the survey period. To our development partners, USAID, ICF, UN agencies including UNICEF, WHO, UNFPA, UN Women, among others, we truly appreciate you for availing financial and technical support for the KDHS 2022. We are partners and you have demonstrated your goodwill to the people of Kenya. We are truly thankful. I wish to inform stakeholders that the Ministry of Health has developed a dissemination plan with the aim of effectively disseminating these findings in a timely manner at national and subnational units down to the grassroots level. It is the expectation that these results will be vigorously utilized at all levels within the health ecosystem to determine how to design and deliver optimal healthcare services. In conclusion, I take note that DHS cycles are programmed for 5 years, which is a very long period to wait for a new set of statistics for planning. Therefore, need to have data on population health more frequently for better planning. I therefore take this opportunity to appeal to our stakeholders to help us strengthen our routine data. We also seek to support in key indicators at short periods and to facilitate the implementation of mid-period DHS when called upon. My sincere appreciation to all who worked hard to ensure successful implementation of the KDHS 2022, the steering committee members, technical teams, and field research teams. Further, thank you all to the survey respondents who opened their doors and patiently responded to the various survey questions. These results will translate to action and contribute to helping every Kenyan access the highest attainable standard of health at all levels within the health system. It is now my pleasure to invite the chief guest to make his remarks. Karibu, Bwana PS.
Thank you very much, the representative of the Cabinet Secretary for the Ministry of Health. Let me first greet all of us. Good morning. In Kiswahili we say, habari yenu. I saw the RC speak very fluent Kiswahili here. Habari yenu. Hello, habari yenu. Thank you very much. I want to applaud the choir. I was very impressed because I saw them sing a statistical or a scientific song. The message was very statistical. It was very scientific because it was talking about the importance of data and how this data, we can apply data for development. I don't know how many of you are listening to that song. I was very impressed, and then I was also able to learn today from the DG that KNBS is not only good in data management, but it's also good in entertainment. Yeah? So, yeah. I'm here to represent the Cabinet Secretary for Ministry of National Treasury and Economic Planning, Professor Njuguna Ndung'u, who has been held up with other duties. I want to take this opportunity to acknowledge the representative of the CS, Cabinet Secretary for Ministry of Health, the representative for the two principal secretaries from the Ministry of Health, Mr. Stephen Wainaina, the chairman of the board of the KNBS, the board members here, the directors from KNBS who are present, Mr. David Gosney, the mission director, USAID, Kenya and East Africa, Dr. Stephen Jackson, the UN RC, and the EPS from the State Department of Economic Planning, Madam Catherine Mwoki, the DG, who is our host of the Kenya National Bureau of Statistics. I like calling him his three names, McDonald George Obudo, Dr. Mohammed Sheikh, the Director General of NCPD, the representative of the Council of Governors, who is with us here, development partners, the senior government officials who are represented here, members of the civil society, distinguished guests, ladies and gentlemen. I'm pleased to join you today for the official launch of the 2022 Kenya Demographic Health Survey results and findings. This important survey is a result of close collaboration between various stakeholders in the health sector in Kenya under the leadership of the very able Kenya National Bureau of Statistics. Ladies and gentlemen, the key indicators report, which is being launched today, provides highlights of key demographic and health indicators on fertility, mortality, family planning, nutrition, child health, maternal health, malaria, non-communicable diseases, and other social demographic indicators. This information will go a long way in enabling monitoring and evaluation of projects and programs implemented by both the national and county governments. Ladies and gentlemen, the survey results demonstrate, as we've all gone through these results, the progress made as well as the challenges that need to be addressed to improve the health of all Kenyans. Some of the key milestones reported include the following from the statistics that we've just gone through. One is the decline in the total fertility rate, the TFR, from 4.9 birth per woman in 2003 to 3.4 birth in 2022. This is attributed to an increase in the CPR. The decline in under 5 mortality from 115 deaths per 1,000 live birth in 2003 to 41 deaths per 1,000 live birth in the 2022. Number 3 is an increase in the proportion of mothers who reported receiving antenatal care from a skilled health provider from 88% in 2003 to 98% in 2022. Fourth, increase in the percentage of children aged between 12 and 23 months who have received all basic vaccines from 77% in 2008-2009 to 80% in 2022. And the fifth observation is a collection of data on mental health, which the CS Ministry of Health has spoken to for the first time ever in the history of KDHS. Ladies and gentlemen, these impressive health improvements are the result of the hard work and dedication by thousands of healthcare workers across the country. I take note of the strong leadership and guidance by the Ministry of Health to ensure provision of high-quality health services to all Kenyans. Ladies and gentlemen, despite the achievements made, the country is faced with a number of socio-economic challenges, including a high level of adolescent fertility, mental health, chronic diseases, high unmet needs for family planning and contraceptive commodity, HIV and AIDS, malaria and TB. The Kenya Kwanza government in its manifesto outlines the government's commitment and determination to realize the constitutional right to health in the shortest time possible by delivering a universal healthcare system. The results of the 2022 KDHS will therefore provide a critical baseline information to inform the government intervention in the health sector that will lead to a healthy workforce, increased productivity, and higher economic growth. Ladies and gentlemen, I take note that high-frequency statistics are key for planning and decision-making. Towards this end, I call for concerted efforts among all the stakeholders in generation of subsequent demographic and health surveys statistics within the required intervals and timelines. I also appreciate, and we are very grateful for the support that we have received from our development partners, especially in the outcome of the current results of the survey that are being launched today. In conclusion, let me take this opportunity to thank all the stakeholders, again, especially the development partners, for the technical and financial support in undertaking this survey. In particular, let me sincerely thank USAID, ICF, International, United Nations Population Fund, United Nations International Children's Emergency Fund, it's the UNICEF, the United Nations Development Program, UNDP, the UN Women, WHO, the Joint United Nations Program on HIV and AIDS, Bill and Melinda Gates Foundation, the World Bank, the WFP, Nutrition International, and the Clinton Health Access Initiative for their generous support. I congratulate the Director General, Kenya National Bureau of Statistics, and his management team for the leadership demonstrated during the 2022 Kenya Demographic and Health Survey process. I would also like to thank the Ministry of Health and all other government departments and agencies that provided technical support during the survey. Finally, let me thank you all for taking your time to attend this important function. With those remarks, I wish to declare the 2022 KDHS Key Indicators report officially launched. Thank you.
Thank you very much, PS. Ladies and gentlemen, we have now come to the point where we go for the actual unveiling and launch of the key indicators report. I wish to request that the media can be ready. Then at 1, please press the green button right there. Okay. So 5, 4, 3, 2, 1. Makofi tafadhali. There you have it. The 2022 key indicators report from the Kenya Demographic and Health Survey. Let us kindly have those who have the books. Those who have the books for chief guests and the parts there so that the photos can be taken. DJ, some music?
Before the report, could you please come here for photos? Thank you.
Those who have the books,
the books.
let's have that photo. Thank you.
So we'll get a quick we will get a group photo of all of you, and then we have to reduce the number to 3 or 4 people. I hope that's fair enough. Thank you.
Madam Kachwa, COG.